Dr. Bertram Karon was a full professor until he retired. He has degrees, high degrees from Princeton and Harvard. And aside from that, he's written one of the most special books under the sun. I'll let him introduce it.
What?
The book. One of your books.
Oh, my book is called Psychotherapy of Schizophrenia, The Treatment of Choice.
It's perhaps the Bible when it comes to understanding the nature of what individuals go through when they're in the midst of in the throes of a psychotic state. It's a wonderful book, and you guys will be blessed to have this on your shelves, no question about it. So I'm going to stop now, and without any further ado, I'll pass the mic back to my friend.
Thank you very much, Bert. Okay, today any unreasonable or excessive fear is diagnosed as a phobia. That's very different from the original psychoanalytic definition of a phobia. This difference in terminology leads to a confusion and a clear difference in recommended treatments. In the words of the American Psychiatric Association Diagnostic Statistical Manual, a specific phobia is a marked and persistent fear that is excessive or unreasonable, cued by the presence or anticipation of a specific object or situation. For many psychiatrists, a judgment of excessive or unreasonable in terms of objective reality makes sense, since their treatment will be a medication that diminishes the capacity to experience anxiety. The source of the anxiety is irrelevant. However, for most psychotherapists, both psychodynamic and cognitive, medication is not an adequate treatment except as a temporary palliative. Given that cognitive therapy is to some extent a historical development from behavioral therapy, it is not surprising that the judgment of unreasonable or excessive for many cognitive therapists tend to be made in terms of objective reality. But for psychoanalysts and psychoanalytic therapists, a phobia has a more specific meaning. The fear must be unreasonable or excessive given the conscious life experience of the individual. Thus, unusually dangerous or painful experiences that lead to an unusual fear does not produce a phobia in psychoanalytic terms, nor would a lifetime of being told by a parent that something was dangerous, even though objectively it wasn't dangerous, lead to a phobia. Nor would identifying with a parent who had an unreasonable fear. These would all be considered fears, not phobias. Most of what is currently being described as phobias are actually fears, and fears respond well to cognitive therapy, that, for example, desensitization. The psychodynamic diagnostic manual, on the other hand, states that to be considered a phobia in the traditional sense, there must be evidence that the exaggerated fear or symptom expresses the way the individual organizes internal experience. Even more clearly, in the section on child and adolescent symptoms, it states, the individual with the phobia is actually not able to explain how he or she became afraid of this benign object, which we assume may unconsciously symbolize anxieties about separation, change, time, or death. We assume that this process is held in unconscious memory by psychological defenses. This is important because a statement is often made that cognitive therapy routinely and quickly is effective for phobias and is the empirically validated treatment. In fact, desensitization, which has been given a number of names, and its variants, is a learning-based treatment which is empirically effective both in clinical work and in laboratory research, and is very effective for fears which are consistent with the conscious learning history of the individual. In psychoanalytic words, it is very effective for fears. Psychoanalytic therapists also recommend it for fears. In addition, cognitive therapists may teach patients to think differently about their fears, but they don't help them discover unconscious meanings. Unfortunately, there are some psychoanalytic therapists who also seem not to know the difference between fears and phobias. Freud recommended that at some stage, every phobic patient must be encouraged to do what they're afraid of. But Freud said that with phobic patients, it isn't important whether they succeed at first, since the attempt will stir up the related issues and make it easier to discover their unconscious meaning. There has long been established laboratory research as well as clinical experience that demonstrates that desensitization is effective for fears which are consistent with conscious experience, but not effective for fears which aren't consistent with the conscious learning history of the individual. They don't decondition, but they do decondition quickly when the subject or patient learns what they're actually afraid of. Thus, psychoanalytic work is very helpful for phobias which involve unconscious meanings. A neurotic patient in psychoanalysis was afraid of flying. The fear of flying may be a fear or a phobia. Despite successfully enduring several flights, this patient's fear of flying did not diminish. During her most recent flight, she defended against her anxiety by a minor dissociation. She felt she could look down from above on herself as a passenger during the flight. She was not psychotic and didn't believe she'd actually left her body. The fear of sexual excitement is not the most frequent meaning of the fear of flying, despite the fact that Freud described flying as a common symbol in dreams for sexual excitement, and the novel Fear of Flying, which was based on that idea. Rather, it is most commonly based on the fear of being confined in an enclosure from which there is no escape, entirely dependent on the good judgment and skill of one person in charge. This turned out to be true for the patient. This patient's associations led to her mother driving the car with her 3 little girls in the back seat. When they irritated her, she would turn and hit them. The patient reported not having been afraid of being hit, but being very scared that her mother turned around to hit them while continuing to drive the car. After discussing this and relating it to flying, the patient's fear of flying disappeared quickly. A neurotic patient, after 5 years of psychoanalysis, was told that it seemed that we had dealt with most of what needed to be worked on, and we should consider interruption. Like many therapists, we believe the word interruption is more useful than the word termination, because patients feel that it is less threatening, and it implies to them that they could return if necessary, which makes life without a therapist less scary. The next week, she had a new symptom she had never experienced before. She was terrified of crossing bridges. She had never had an accident on a bridge, nor had she known anyone else who had an accident on a bridge. One would have to be a very stupid psychoanalyst not to be able to guess what bridge she was afraid to cross, but the patient made no connection. However, her associations to her fear of bridges led to her fear of separating from her therapist, as well as her wish to separate, which in turn led to her fears of separating from her father and mother, as well as her wishes to separate from them, and their threats, explicit and implicit, of the dangers of separating from them. But that was not the major issue. There were childhood experiences in which her alcoholic father would come home and reach under the cover and fondle her. She did not know what to make of it. She did not think he had sexually molested her, although she wasn't sure. At first she said she wasn't scared of him, but then said that she would go to the bathroom before he came home, lock herself in, and stay there until he was asleep. She had never told anyone about these experiences or her feelings about them, too ashamed to discuss them, even though she had been in helpful once-a-week therapy for 2 years as an adolescent and had now been seen for 5 years and 3 times a week psychoanalysis. After discussing in her analysis these experiences with her father and her feelings about them, she not only lost her fear of bridges, but successfully interrupted her analysis. Obviously, at some level, it was important to her that she did not cross the bridge of terminating therapy until she had been able to discuss this important childhood problem and its meanings for her. A psychotic patient in psychoanalytic therapy was terrified of putting on his socks. He feared he had had no scary experiences with socks. His associations led to the socks being a round hole that he put his foot in, and he was scared. His associations then led to the round opening being like a vagina, his mother's vagina, which he was afraid would injure him. Our discussion ended his fear of putting on his socks. This grossly psychotic patient then continued to explore the myriad of delusional ideas and symptoms in long-term psychoanalytic therapy. The meanings of his delusions that he was going to be forced to have intercourse with his mother or with a woman symbolic of her, and his fears of injury and castration by the vagina, as well as the wish for castration, have been described previously, which was reprinted in my book, Psychotherapy of Schizophrenia. His problem was resolved after a total of 5 years of treatment. 2 years on a 5-day per week basis as an inpatient and 3 years as an outpatient. Psychoanalytic therapists, like most competent therapists, do not treat just one symptom, but everything that needs attention. His recovery has been enduring for at least 30 years when last heard from, despite his earlier 16 years of psychosis, during 8 of which he was hospitalized, before he began psychoanalytic psychotherapy without medication in a long-term residential treatment center. Unfortunately, such long-term psychotherapy for psychotic patients is even rarer now than it was in the 1950s. The importance of the distinction between fears and phobias is clear for psychoanalysts and psychoanalytic therapists. Cognitive therapists who have a phobic patient who does not respond to cognitive therapy will find it helpful to evaluate whether the patient's conscious learning history is consistent with the fear, and if it is not, to consider a consult with a psychoanalytic colleague or even a referral. Most of what are currently called phobias are actually fears, and they respond well to cognitive or exposure therapy. But patients with true phobias, fears that are discrepant from their conscious learning experiences and which involve unconscious meanings, do not respond to cognitive therapy, but they do respond well to psychoanalysis and psychoanalytic therapy. 3 very different patients have been presented as illustrations of the unconscious meaning being made conscious as the treatment of choice for phobias. Thank you.
So we have some time for some questions. If anyone would like to ask a question, I'll ask you to just speak up. I won't run around since I'll hold the mic for Bert here. Any questions about that? Go ahead.
I wonder if you could just describe more of the process you would use, kind of like, I don't know if you could go through it kind of step by step, like let's say somebody does have something that's clearly a phobia, it's not explained by their learning history. I mean, do you first just ask for associations, or then just how do you do it?
How do you do it?
Yeah.
Oh, you ask a very strange question. What comes to mind? And then you listen carefully to what they say. And guess what? It makes sense, and when it makes sense, they get better.
Any other questions you would add to further the discussion? Because sometimes people
Right.
might not say much initially.
So it sounds like what you're describing is, you know, what a Jungian would call amplification. Would you say that you're amplifying through the discussion?
I don't know. I would just say we're finding out what it all means.
Okay.
I'm curious as hell, and the important thing is that you and the patient have to get that feeling that you're on the same side, and you're going to deal with anything they need to deal with, and you want to know what the hell comes to mind.
Okay.
Yeah.
Go ahead.
In sometimes some of the eating disorders treatment, they are desensitizing patients, but these are not patients that are, this is pushed upon them. And I see a clear difference between a self-directed, self-chosen desensitization that someone may do with somebody guiding them, or do completely on their own, say, okay, I have a fear of walking into, this is an example, fictitious example. Okay, here's a person who is afraid of walking into a grocery store, and they
Afraid of doing what?
Afraid of walking into a grocery store.
Okay.
For
good.
various reasons, you know. And so they may say, okay, I'll try walking into a smaller store or one with less advertising to get used to it. And they do this entirely on their own. Is there a difference between that and desensitization that is pushed upon a person? Okay, you're going to the grocery store, that's it, we're going, and we're taking you all in a van, that kind of thing.
Well, I'm trying to recall. I have a feeling that somewhere along the line I did have a patient who was afraid of going into a grocery store. But I don't remember. I think, again, I found out what it meant. It had meaning to her. And it had to do with making choices and not being allowed to make choices. But again, it's been a long time, and I don't really remember the details of the case.
I wasn't asking about specifically fear of grocery stores, but any fear, that was just an example, you know, any fear that you might have.
What I heard,
An actual fear, not a phobia.
what I heard you saying then, Dr. Karon, is that you were less focused on trying to get someone into the grocery store through systematic desensitization, and you were much more interested in what is the meaning of why the person wouldn't get into the store,
right.
And you had no agenda to get them into a store.
Yeah.
Okay.
Yeah, that's exactly right. That's exactly what I would be doing.
So you do not focus on desensitization at all. I mean, I'm saying some people make their own decision that they're going to desensitize, the self-directed desensitization through, you know. Okay,
And I would guess that where that
I'm
worked, that there was some reason that going into the grocery store was made scary for them by somebody else, but that it was an experience they had. And again, it depends. If they know what that is, fine. If they don't, then we have to find out what it means. Yes, please.
I think what's sort of being asked too, Bert, is what my Bert would often say, how do you get a person to become a patient? As in, you've got a lot of folks who are sent to treatment. And
How do you get a person to become a what?
a patient. In other words, a lot of people are sent to treatment, whether they have an eating disorder or an addiction or social anxiety. And I think people are asking, how do you engage people in the therapeutic process?
Well, right in the first thing I ask them the first time I see them is, what seems to be the trouble? And then I take seriously anything they say. And even if what they say is the problem, is not what I think is the most important problem. I try to deal with that problem. And once they find that you actually want to help them, because, you know, they have a lot of experience in treatment systems with people who really don't want to help them, who don't want to understand them, who don't really want to deal with them, particularly if they've got serious symptoms. And it's clear that you want to know, you want to understand, and you want to help them, and they respond to that.
I have some questions about what constitutes a phobia, because it was clear that you were pointing out there's a difference, that a phobia really has an earlier unconscious meaning.
Right.
And it's unconscious at the time, whereas a fear is really something that has a conscious history, and something happened, or the person is aware of it. Well, I was wondering, though, the classical phobias I deal with frequently are things like step on a crack, you break your mother's back. Someone literally can't get to school because they're jumping over the cracks all the time.
Yeah, well, of course, all kids play with that nursery rhyme, but it doesn't keep them from doing anything.
Exactly. But it also suggests that maybe they have an unconscious aggression towards the mother or something.
Oh,
that's
sure.
implied in that, and they're oblivious of it. They're unaware of it.
Sure.
And it comes at a time frequently when young girls really are having a lot of aggression towards their mother, or they feel controlled or whatever. And the other one I thought of is a common phobia or seeming phobia or fear is elevators. People are always afraid the elevator is going to fall. But that's the only association they have to it. They never fell, they were never in an elevator, but they have a fear, a phobia almost.
And I would have to try to get them to associate to it.
Right.
And I would think that if we talked, we would discover that it had scary meaning. Yeah. Yes, please.
Do you ever ask a question other than what comes to your mind?
Probably, if something comes to my mind, but most of the time, that's what I ask. What comes to mind, and that's all you need to do. If you get them talking, they lead you right to what they need to talk about.
Okay. You give them half a chance, they'll do it, huh?
Yeah, but they really, I mean, we have a lot of people who are called treatment people out there who really don't want to help the patients. And so when they get the feeling that you actually want to help them, and if in fact they tell you something and you were able to give them either some meaning or even good advice, they get impressed. They build a therapeutic alliance. And as you know, whether people get better in therapy or not depends mostly on whether or not they form a therapeutic alliance between the patient and you.
I should add that I've been a patient of Bert's, and I know that Bert does do some interpretations also. He has some pretty good interpretations he can throw at you.
I have a question for you. You have an individual that comes to your office,
right?
Who is brought by a parent who is a young adult.
Right.
When you ask and say, you know, how can I be of help, or what seems to be the problem, and they say, there is no problem, but they like coming to you. So you've built a rapport, and they want to be with you and talk, but they come in and they talk about just daily life skills and things going on and movies, but they really don't address any concerns or problems. But they want to come every week, and they say that they'd like to come there every week.
Well, now, my guess is that if they did that, and I don't really think I've ever had a patient like that, so, you know, but I would think that they're there because they hope I will talk about something important. And I guess I might even say to them, look, I wonder if there's something that's bothering you that you haven't really been willing to share with me. And if it's bothering you, I want to help you.
Okay. Thanks.
Yes.
What do you do with a patient that won't talk? That just comes in and says,
Oh, well,
doesn't want to talk?
now, there are several things you can do with a patient who won't talk. One thing is that you can say, well, you know, maybe you just don't have enough words. So if you don't have enough words, I do. And then I'll talk for the whole hour. And then I'll talk for the next hour. And after a while, the patient gets tired of this and says, I'm tired of hearing you. And I remember saying to one patient, well, I can keep on doing this for 6 months. And the patient at that point, who hadn't talked for 3 hours, said, you must be crazy to talk that much.
No, I'm reminded of Dan Dorman's book, Dante's Cure, where he said, I think it was maybe the first 7 weeks or 7 weeks.
A month.
That Catherine sat in his office and said nothing. So he sat there and said nothing. I don't know what was the answer he
Now,
said?
by the way, about people who don't talk, if you really have a catatonic patient,
Yeah.
there what you have to do, people get catatonic because they are terrified.
Okay.
So you have to tell them that you're not going to let anyone kill them. Now that seems crazy to do this. They may not have said anything about it, but it's been my experience that if you say this to psychotic patients, they act like you've given them the Holy Grail. I mean, because they actually are afraid they are going to be killed. And I remember one patient where I said this, and then he began talking to me, and then later he said, you know, when you told me you weren't going to let anybody kill me, that was crazy. And I said, yes, it was. And he said, but you know, I needed it. And, you know, quite clearly, you're on the patient's side. You're not going to let them get killed. You're not going to, and you are going to help them deal with anything that they need to deal with.
John at breakfast that he had a patient that said, I'm going to kill you. And he said, how? Right?
Yeah.
About insomnia, would you address that as a fear or a phobia? Because,
Insomnia?
Yeah, I was just curious.
Well, you know, I have a bad habit. I've read lots of people. And there was a guy named Alfred Adler. And he talks in his books about the fear of sleeping. And what he said is what nobody else that I know has ever said, but it seems to be true. If you lie there, wide awake for 8 hours, that's as good as 6 hours of deep, sound sleep. And I have tried this, and it works. That is where I've had to lecture the next day, and I'm on, I don't know, a bus or a train, and I can't sleep. But in fact, the next day I can function perfectly well.
It is true. I had insomnia 5 years, and I know it was from the drugs that destroyed my ability to sleep because I was on such a polypharmacy for so many decades. And I would finally, they would say, oh, you got to get up, get out of bed if you're lying there. I found out that that wasn't true. I found out that, okay, I was going to lie there, I was going to doze for an hour, and the rest of the night I was not going to be sleeping, but I just lay there, and it gave me enough rest to function a little bit in the day. I would still be tired, but that's how I survived 5 years of insomnia.
Mm-hmm. Yeah, I find, you know, that we've had a lot of bright people in our field, and a lot of them have had very good ideas. Yes, Ron?
Yeah, I think, you know, you do know a lot about states of real acute terror, and that's important, but like, I'm thinking of somebody that gets into a state of terror, but his terror is about that there's some kind of evil inside him which is going to lead to him being eternally damned. And I have a hard time saying, well, I can stop that from happening. But anyway, that's what
Okay, he's afraid that this evil is going to come out of him.
not just going to come out of him, but it's going to lead to his internal damnation just by what it's doing to him inside.
Oh, okay.
That's scary.
It's a good question. Eternal damnation. Well, it depends on, again, you know, you're a damn good therapist, and I go with your intuitions, but I think if he says he's afraid of eternal damnation, I would tell him that isn't true. Some people think that if you have bad thoughts, you will get eternal damnation. But nobody can control their thoughts, and you don't need to do it. You only need to control what you actually do. If you actually go out and shoot someone, you should feel guilty about it. If you want to shoot someone, that's fine. It does them no harm at all. And it's okay to have any kind of thoughts. However, tell me about them, and we'll see what we can learn. Now, that would be my guess. I was just talking, you know, so people hear voices, and one of the voices that they hear is God. And if God tells them to kill somebody, you tell them that no, God, that's not God. God is not a sadist. If God tells them to kill themselves, you tell them that is not God. God does not want you to die. And we'll have to find what that, but I wonder if there was someone in your family who did want you to die. And now I do know that early on, I once said to some woman that voice wasn't God, and she hit me. And then I realized, well, suppose you had a direct line to God. Wouldn't you get pretty angry at anyone who tried to take it away from you? And so I've learned to be a little more tactful since then.
There's a question way in the back.
Oh, yeah, please.
A lot of people, I run groups and individuals where there's a lot of individual therapists, and I run groups and people tell me things, and I do individual therapy too. And I'm wondering if, because there's a lot of disruptions.
Would you do me a favor and talk louder, please?
Tell you what, I'll come up by you for a moment.
Thank you. I want to address what you think about disruptions in the therapeutic relationship, and do you ever take a very direct approach about that? Where I work, we have this form, and it says, do you feel there's a problem in the treatment relationship? Agree, strongly agree. And at the end of the sessions, we're encouraged to say, you know, how are we doing here? Are we doing okay? Are we on track? Keep the relationship on track. And I'm wondering what you think about that. Personally,
well, I would say, what's your experience with it?
I like it. I'm like, wow, you don't really agree that we're on track together. I thought we were getting along just fine. But it gives me an opportunity to say, you know, we used to strongly agree with our treatment approach, and now it's just agree. You know, what's the difference here? How can we come together? How can I be more of help to you? And it's a new thing we're doing, and I just wondered what you thought about it, because to me, the therapeutic relationship, it's a very hard thing to be direct about with clients, patients. They have a hard time to say, you know what, I'm really offended by the way that you talk to me, or whatever it is. And how do you, in your practice, approach the therapeutic relationship, which is the most important thing, in my opinion?
Well, yes, the therapeutic alliance there's lots of research showing that if there's a therapeutic alliance, the therapy tends to help the patient. If there isn't, it tends not to help the patient. And asking the patient about how things went makes perfectly good sense if you pay attention to it. I'm sorry, I can't.
How often are you, or have you been asked by a patient to help them interpret their dreams or dreams?
How often have I what?
How often have you been asked to help a patient or someone interpret their dreams?
Well, since I'm a psychoanalyst, I talk about dreams all the time. And I say, have you had any dreams? And then if they tell me about them, I say about each detail in the dream, what comes to mind? And that secret was first disclosed to me by reading Sigmund Freud. That's what he said you do. You ask people about their dreams and get their associations to it, and that leads you to what's going on. And it works. It's very helpful.
Because I bug her every morning with mine.
I remember my first analyst told me, don't analyze friends and family.
Don't analyze what?
Don't analyze friends and family.
Oh,
because
yes.
Where power enters, love exits.
Well, as Freud said, don't analyze a friend or family. It's not that you can't analyze them, it's just that they will no longer be your friend.
Question?
Yes.
Since there are these common dreams, such as being topless or bottomless, or treadmill dreams when, you know, university students can't get to their test, they're on a treadmill, they just can't get there, or they skip the whole class in their dream, and then they show up at the final exam, these common dreams. Do you have interpretations that come up frequently of these particular dreams?
What was the dreams? I'm sorry, I didn't.
Well, one of them, this been being common, that you're walking down the street, all of a sudden you notice an article of clothing said that the whole top of you is missing, you're naked up top, or you're naked from the waist down in the case of usually a man, or another dream being college student can't get to their class, they feel like they're on a treadmill.
They can't get to what?
Their class.
They're on a treadmill,
Oh.
and they cannot get
Well,
to their
again,
class.
what I would do, look, even if some of these things are classical symptoms that have been described, it's more important to get the associations of the patient to their dreams. And very often they will give you the classical meaning, but sometimes they'll give you something entirely different that you didn't even think about. But if it's their association, that's what you should be talking about. Well, I guess I guess I've tired you all out. So.